Hello and welcome everyone who's joined us today. Hope you and your near and dear ones are staying safe and well. And warm greetings, Professor Kang, Professor Reddy, Dr. Anish, and Dr. Satwik. It's an absolute pleasure to be in conversation with you. May I request you all to please switch on your videos and audios so that we can begin this conversation. And I must say that over the last 2 years, informational webinars like these have been absolutely crucial in helping us understand the scientific evidence that's out there to really help us make sense of the behavior of the SARS-CoV-2 virus and also the disease it causes, COVID-19, so that we can take better care of ourselves, our families, and communities. So in today's webinar, we will try to make sense of the pandemic as it stands today. What do we know about the new virus variant Omicron that's on a rampage in many countries, including India at the moment? And where are we really headed with this pandemic? And what is that we should not lose sight of? So to begin with, Professor Kang, if I can bring you in first, what do we know today for certain about the biology and immunology of the new Omicron variant? And how does it compare to the previous variants of concern of SARS-CoV-2? And if you could also talk a little bit about the biological characteristics of this variant that makes it more transmissible, but less severe or less virulent than the Delta variant, which we saw in the second wave. So over to you, Dr. Kang.
Thank you, Sarah. I'd like to take us back about little over 2 months ago when we first got the news of the Omicron variant. Feels like forever that we've been living with it, but that's not true. When we first heard about this variant, it was extremely worrying, because we never had a variant with quite so many mutations before. Just if we look at the variants that we had seen that had become variants of concern previously, most of them had mutations in the spike protein region, where it allowed for them to attach better to the ACE2 receptor. But if we compared Delta's sequence with the sequence of Omicron, you had over 30 mutations that Omicron had when Delta had little over half a dozen. So when we saw that, it was like, wow, we have no way of understanding where this could go. Two things were already clear from that early sequence data. One, that it was going to be something that was likely to attach better to the ACE2 receptor. The second was that this was going to be a variant that potentially could escape the immune response. Both of these turned out to be correct. This is the variant that has the greatest amount of escape of antibodies, and it is the variant that is most transmissible. Fortunately for us, it also turned out that in the population with the infection and vaccination experience that we have had so far, the disease that has been caused has not been as severe as was seen with the Delta variant in a naive population. It's still not clear whether this is an intrinsic lack of virulence or it is because we have some protection from our prior exposure. The one thing that is biologically different is the site of replication of the virus, where it does seem like this is a virus that replicates well in the upper respiratory tract and in the larger passages that head down into the lung, but it doesn't replicate in the lung the way other variants have. Is that responsible for the less severe disease? It's certainly possible, but not guaranteed at this time.
Yeah, that was quite helpful, Professor Kang. And is that also why we are seeing the different variants are resulting in different symptoms, and it's got to do with these mutations that we're seeing in these different...
Well, actually, this is the first one that is replicating in a different place from the others.
Right.
If we look at alpha, delta, beta, all of them had the capacity to cause more severe lung disease.
Right.
But most of them hit us when we had less experience of infection and less vaccination. This is the first variant after the bulk of the world has received some level of immunization.
Right. Thank you. And so maybe Dr. Satwik, if I can bring you in next. We know that, and like Professor Kang also mentioned, that SARS-CoV-2 is a respiratory virus, but we know it doesn't limit itself to just damaging the lungs, and it has shown to impact other organ systems. So how well have we characterized the clinical symptoms of COVID, particularly the current variant of interest, Omicron? And it would also be great if you could remind us of the observable similarities and differences between the symptoms of these different variants, starting from the beginning, so that we can put all of this in some sort of context. And
Indeed, thank you. Thank you for having me. As Professor Kang pointed out, that it's fundamentally the same virus with a whole new set of mutations. And it's quite instructive about how she mentioned that one is not entirely sure if this is an intrinsic lack of virulence in the virus, or you're seeing it behave differently because it is encountering a more bolstered immune population. And one way of explaining this is something called a Simpsons Paradox, which is when you see a trend because you're fundamentally mixing two populations. So the populations that you're mixing here would be the population of the immune and the population that is naive to the virus. So let's, for the sake of argument, consider that Omicron is more virulent than Delta, for the sake of argument. And let's take some numbers if I were to explain that to you. Let's say that in the population that is naive to the virus, Delta has a fatality rate of, let's say, 1%. Okay. And in the population that is immune to the virus, Delta has a fatality of 0.1%. So the combined fatality rate, the average fatality rate would be 0.9%. But Delta strikes when 10% of the population is immune and 90% of the population is naive to the virus. All right. Now, let's consider Omicron, and for the sake of argument, consider that it's slightly more virulent than Delta. Let's say the fatality rate is 1.1% in the naive and 0.3% in the immune. So the average fatality rate is 0.38%, because when Omicron strikes, 90% of the population is immune and 10% is naive. So what you're seeing as a decrease in roughly about 60 to 65% of virulence is actually not true, because intrinsically the variant is about 20% more virulent. But this is why we were still considering what to pronounce on Omicron when we were first encountering this virus. But now you do have ex vivo studies and also animal models, and also observationally, empirically, and experientially, what we're seeing is that the virus isn't really growing that well in the lungs. The incidence of COVID pneumonias is much, much lesser than what you saw in Delta. I mean, any respiratory mucosal pathogen, any respiratory virus has the potential of giving you pneumonia. I mean, the common cold virus can give you pneumonia. That's the origin of the phrase "bless you" or "Gesundheit," because it goes back to actually pneumonic plague. But it's just the idea that any cold virus can give you pneumonia. But what you're seeing with Omicron as compared to Delta is that you're not seeing too many cases of growth in the lung, and the two great complications of growth in the lungs, which were a dysregulated cytokine response and immunothrombosis, which would happen as a response to marked inflammatory release due to growth in the alveoli of the lungs and due to recruitment of white blood corpuscles, isn't really happening. I remember in Delta, we are a high volume vascular center, and we were doing roughly 5 to 7 cases of arterial thrombosis, thrombectomy in the surge in Delta, we have not seen even a single case of arterial or venous thrombosis associated with COVID currently. And as Professor Kang mentioned, that this could be a sort of Pyrrhic victory. It's possible that the ravages of Delta, because it spread like a conflagration in April and May, it's possible that the ravages of Delta are preventing any great severity of disease from manifesting in our communities during the current surge, but also that we have a much larger population that is double vaccinated. So the metropolitan areas of India offer very good hybrid immunity, and that's why what you're seeing play out is quite similar to what happened in South Africa, where the numbers surged, but the hospitalizations did not.
Yeah.
And just one little thing that I'd like to mention, I think because in our hospitals, we are seeing so many incidentally diagnosed COVID cases amongst the hospitalized, already hospitalized, and those that are being hospitalized for other reasons. I think hospitalization rates will not be a very reliable indicator of severity of disease as regards Omicron. You'll need more granular data to actually pronounce on this. Perhaps excess ICU admissions or excess mortality audits will be required to tell us about what the real cost of Omicron was.
That's really helpful, Dr. Satwik. I'm not sure if you can hear me. Having some issues with my internet. Are you able to hear me?
I can hear you, yes.
Okay, wonderful. All right. I'm just going to keep my video off because there's some internet issues on my end at the moment. So that was really helpful, Dr. Satwik. Thank you. And I also want to ask you about, there's been a lot of uncertainty and misinformation around treatments, what treatments are currently effective in treating COVID patients. In fact, Dr. Kang today posted on Twitter about how some doctors are prescribing monoclonal antibody therapy for Omicron infections when these antibodies have not been found to neutralize Omicron. So just for the benefit of our audience, can you maybe clarify, what kind of evidence-based treatments are available to treat COVID patients with mild symptoms and those with severe symptoms as well? And also if the treatment is changing depending on the variant that has caused the infection. So if you could clarify, that would be really helpful.
Well, you now have guidelines issued by ICMR about how the treatment algorithm should follow. And as any other viral ailment, this is also self-limiting. So I don't think a large bulk of patients will require any kind of treatment. Right. It's a self-limiting ailment. Usually it'll run its course in about 5 days to 7 days. And will not need anything other than symptomatic treatment, which could be paracetamol in response to fever, antihistaminics, steam inhalation, and perhaps a couple of anti-inflammatory analgesics if there's severe body ache. There's been a lot of discussion on antivirals, and most of the data on antivirals actually comes from Delta. Okay, because there's been a lot of discussion about how a certain kind of antiviral will decrease the risk of hospitalization by 80%. But this is data that comes from Delta. When you already are dealing with a virus where the hospitalizations are much, much lower than Delta, one would question the need for such antivirals. And at least one such antiviral could be mutagenic. So a lot of experts have advised caution against indiscriminate use of such therapy. Also, the current monoclonal antibodies that are available in India have been demonstrated not to be effective against Omicron. And again, because the severity of the disease is experientially quite low, there's absolutely no point in adding anything unless one is dealing with demonstrable COVID pneumonia or cytokine dysregulation, when a whole other set of drugs are then employed to treat this. If there is persistent hypoxia, which is unresponsive, there might be an indication for starting steroids. There are other categories of drugs that are used for a dysregulated cytokine response.
Right.
But that, I think, would be beyond the purview of this discussion.
Right. Thank you. That was really helpful, Dr. Satwik. So, Dr. Reddy, we've been hearing a lot about long COVID, or the long-term health consequences of COVID, and there's not really a lot of research out there or evidence out there to tell people that it's okay, you can get infected, and that's nothing will happen after that. You've sailed through this wave, but there are a lot of cases of people suffering with very severe ailments or after effects of the infection. So is there any ongoing clinical research in India or other countries to understand the impact of COVID in rehabilitating COVID patients, or even those with who had milder symptoms? And what is that telling us about long COVID that we're talking about? And of course, I would love to hear other speakers weigh in on this as well. So, Dr. Reddy.
The fact that long COVID exists, I think, is beyond dispute.
Right.
Whether it was after the initial viral attacks of 2020 or subsequently even after the Delta, there have been many instances reported, including with reasonably objective investigated evidence of effects on multiple organ systems. Now, the question, of course, is how long will they last?
Right.
What is the potential pathway of management?
Right.
Those are issues that are, I believe, still being unraveled. We have seen beyond 12 weeks, which is generally taken as the cutoff point, where the symptoms have persisted for several weeks beyond that, but have subsequently regressed. And we have seen that there are people who have been suffering from some of the metabolic complications of damage that was caused during the infection itself, while myocarditis seems to recover reasonably fast. We have seen persons with diabetes, which was actually for the first time noticed after the COVID infection, continue. So there are different organ systems which have had different effects. And the neurological effects are also being quite noted, apart from the brain fog, which has been noted in a number of people. There have been also organic changes that have been documented. So I think this is an area of ongoing study. There are a number of registries in many countries that are studying this. There are some international collaborative studies on this. Even in India, the Indian Council of Medical Research and All India Institute of Medical Sciences are leading a major study on studying the effects of long COVID. But the actual methods of treatment in terms of a specific drug is not really at the moment available in terms of any conducted clinical trials. Right now, it is much more symptomatic and specific to organ ailment, which is attracting clinical attention. But in terms of a definitive response to long COVID, which can actually tackle and reverse all of the manifestations of long COVID, whatever they may be in terms of their diversity, right now we don't have a clinical evidence available as to such a intervention.
Right. That's very helpful. Thank you, Dr. Reddy. And would the other panelists want to weigh in? Would you like to add anything on long COVID based on your experience?
Let me add, Dr. Anish.
Sure, Dr. Anish. Yes, please.
Thank you for being me in this panel. I want to add something what Dr. Reddy has already said. If you want to manage long COVID in a country like India, it is very important to build the system in place. Because in India, so many people are going to be suffered from long COVID, and it is going to affect in nook and corner of the country. And we cannot build a dedicated system to take care of long COVID. It could be managed through the healthcare system available in India. So our primary healthcare, maybe our hospitals and all other things should be strengthened, so that in the future it is going to be a big issue, because we are moving to a epidemiological transition which is dominated by non-communicable disease, and COVID-19 is going to bring some sequelae in terms of non-communicable diseases like this, and we have to manage this problem in our local hospitals and our primary healthcare itself. So we have to build a system in our primary healthcare system itself, so that we can tackle long COVID maybe better. That may be a better option for us. But
yes, that makes a lot of sense. Thank you, Dr. Anish. And so we've also been hearing about the subvariants of Omicron in India and other countries, but not much is known about them as yet. So what is this really telling us about the behavior of this variant, whose arrival, by the way, as we also mentioned earlier, was being hailed as the beginning of the end game of COVID. And so maybe Dr. Anish, if you can tell us, is this dreaded SARS-CoV-2 virus on its way out? Or is it here to stay for a while, as the emergence of these subvariants suggest? And so what is the current epidemiological data telling us about the course of this pandemic?
Actually, we cannot say anything at this point of time. But as an opportunity, that's optimistic always.
Correct.
I also think that as a variant which has got this much transmission potential, is spreading like anything, and there may not be a large outbreak or a pandemic like this. A new variant cannot perform like this anymore. So sometimes this may be the last big surge of the pandemic. Definitely, this is going to mutate again, and it is going to. Some other variants are also emerged, but that may not be as efficient as Omicron. And it may be creating some issues here and there, but this will be the largest outbreak ever in case of COVID-19, and it may help to reduce the teeth of the pandemic. That is what I also feel. But it is very early to say anything. But definitely, as Dr. Kang has already pointed out, we have got some evidence that this is a mild type of variant. And it is multiplicating in our bronchus or some respiratory airways, upper respiratory system. The virulence is not that much high in terms of creating COVID pneumonia as well as thrombotic events. Definitely, I am also actually coming out of the disease. I was suffering for this infection for last a couple of days, and I have got severe throat pain. Throat pain was the only symptom I had, and I did not have any other problem. And now I am actually completely out of that. I also feel that this is very mild. But I have, as a medical doctor, I have took 2 doses of vaccine, and then I took a booster dose. Maybe because of the immune response might have helped me. Definitely that is something very important. But I think we are going out of the clutches of the pandemic. But that is what I feel. But definitely that is because of my optimism. We have to be very careful, and we have to monitor the new variant that is emerging, and we have to keep the maybe mask and all other COVID appropriate behaviors intact. So this is not some time to relax ourselves, but we can be very optimistic. Definitely.
Right. Thank you, Dr. Anish. And in case of the 1918 Spanish flu pandemic, after about 2 years, the virus became seasonally endemic and sporadic, and it kind of disappeared entirely after 11 years. But of course, we're living in very different times. We have vaccines, we have better mitigation strategies, better public health interventions. So, Professor Kang, can you help us make sense of the evolution of the virus in the larger context of how viruses usually evolve, and particularly pandemic viruses? So, what are some factors that impact their evolution, maybe?
Well, first, no 2 pandemic viruses are alike. Our last pandemic was in 2009. And the virus that we had then is an endemic virus now, H1N1. And the H1N1 that we have currently is called the swine flu virus, but actually contains genes from bird flu viruses, swine flu viruses, and human flu viruses. So influenza viruses are different from coronaviruses. Coronaviruses, 4 RNA viruses, are at about the limit of the size that an RNA virus can be. It's a single-stranded genome. And in fact, it is a virus that evolves very, very slowly compared to other single-stranded RNA viruses. I know it sounds really odd to say that, but that is actually the case because this virus has a proofreading enzyme. So when it makes errors, when it copies its RNA, it is able to correct those errors. This enzyme is called an exonuclease N. And coronaviruses and RNA viruses that have a really large genome, above 20 kb in size, have this particular enzyme that allows for error corrections. However, coronaviruses are a little bit different also. And one of the reasons that you get so much cross-species transmission, much less host restriction than is seen for other viruses, is because their genome is capable of something that is called viral recombination, which is they can swap out segments of RNA. And this has been demonstrated for all of the coronaviruses that are found in humans, including the ones that cause the common cold, as well as for SARS and MERS. So basically, mutations arise, can be corrected for the most part. The reason that we are seeing so many mutations is because the virus is replicating at such high levels. It's infecting so many people. So it has opportunities to keep replicating. And recombination, we have seen, is already happening. This is a virus that goes into zoo animals quite easily. And the latest story, of course, about almost all of the white-tailed deer in America being infected with SARS-CoV-2 is another example of how easily this virus can spread to animals and back again.
Right. Thank you, Professor Kang. That was helpful. And so maybe, Dr. Reddy, I mean, what should we not lose sight of? I mean, of course, Dr. Anish is optimistic about that maybe the pandemic of COVID-19 is on its way out. But in the times to come, in the month and the year, and this year 2022, what is that we should really not lose sight of as we continue to tackle this public health crisis in our country? And Dr. Satwik, I would also love to hear your thoughts on this as well.
Well, firstly, while we must keep an eye on the behavior of the virus and see how it is changing forms or whether it's going to be relatively more stable, I think we also ought to adapt our behavior in such a manner, not only to be responsive to the behavior of the virus, but also to try and influence the behavior of the virus. I think it's absolutely important that if we believe in evolutionary biology of viruses, that if we actually restrict the opportunity for a virus, especially a respiratory virus, to spread fast and far across several human bodies, then the virus will have a sort of stimulus in order to increase its infectivity, perhaps acquire a bit of immune evasion, but more importantly, reduce its virulence, because if it has a limited number of human bodies to infect, it is unlikely to extinguish them, because then it sort of extinguishes its own progeny and the ability to continue to exist. And therefore, it is absolutely important for us firstly not to provide an opportunity to easily transmit. And that we do by wearing masks, which are possibly our most potent weapon right now, in order to prevent transmission from person to person. Of course, ventilation, physical distancing, all of these are important. Avoiding super spreader events, these are important. But I believe masks are perhaps the most important element that we must ensure universally. Then, of course, do not offer human bodies or persons where it can stay long if it is infected. Because if it has a person who is likely to be relatively immunodeficient or elderly and debilitated and is unable to really expel the virus fast from the body. And if this gets into a long stay visit in that body, then it has an opportunity to replicate many times and therefore mutate many times. And some of those mutations will have an evolutionary advantage of continuing to spread further and also become immune evasive to vaccines and natural immunity. So the two important things are ensure that everybody is masked and avoid super spreader events for some time to come. And secondly, ensure that vulnerable people in whom the infection is likely to last long are adequately vaccinated and protected so that they do not play host to a virus which can become a long stay visitor and thereby mutate into further forms.
Yes, that's right. Thank you, Dr. Reddy. That's really helpful. Dr. Satwik?
Well, one of the theories that has been forwarded to explain the origins of Omicron is that this actually comes from mice, because the molecular spectrum of mutations that is found in Omicron is not the sort of spectrum that would be seen if the virus were to evolve in a human host. It's the sort of spectrum that's seen when it were to evolve in a murine host, particularly mice. And there's been some work and there's been a couple of papers on this. But this also seems to suggest that though humans seem to be the largest reservoir of SARS-CoV-2 currently, but because of our affinity to livestock and pets and other sorts of animals, it's entirely possible that, as Professor Kang pointed out, this virus might jump host and undergo a whole new series of mutations. And it's also likely that some of those mutations might not be fortuitous for humankind. I mean, it's a magnificent great fortune that the set of mutations that happen, let's say, if it did happen in mice, are the sort that aren't allowing the virus to grow in the lungs particularly well, which is the source of all great severity of COVID. But therefore, I think it's entirely possible that you could have cyclical emergence of various kinds of variants, some of them with significant antigenic shift, which might cause some global distress. But I think from the public health point of view, it's important for us to realize that our response shouldn't be one of maniacal aggression, and also that it's not possible to have zero COVID. So the manner in which perhaps China is proceeding on clamping down may or may not be the right way. We saw a similar kind of panic in India in some of our main cities when Omicron was emerging. You had people coming in from overseas travel being forcibly incarcerated in hospitals, even when they were asymptomatic. Right. So this kind of almost maniacal aggression without following science, I think, is not advisable.
Absolutely. Can't agree more with you on that, Dr. Satwik. And so, I mean, WHO and all of you have also been, WHO has been continuously telling countries to track, monitor, and assess these variants and how, this virus is mutating and how variants are coming about and also transmitting. So we recently heard that 5 labs in India, which were part of INSACOG, the Indian SARS-CoV-2 Genetics Consortium, shut down due to shortage of reagents. So how well are we doing? I mean, of course, India has very good capacity for genomic sequencing and we've been doing fairly well so far. But I mean, what are your thoughts on how we're doing right now with genomic surveillance? Because I think it's going to be quite critical in mitigating the crisis in the times to come.
Is that for me?
Anyone can take that up, but yeah.
Right. I mean, look, I think, of course, we have several labs which are capable of sequencing, but our per capita genome sequencing isn't anywhere comparable to the global West. But also, I'd like to perhaps seek Professor Kang's opinion on this. perhaps artificial intelligence can be used with statistical and almost algorithmic identification of possible changes in this amino acids of the spike protein to look for and predict putative future variants. I'm not too sure where the science is. There's been some work done on this because otherwise we'll be constantly chasing the virus. And I seek Professor Kang's views on this.
Well, I think the use of approaches, computational approaches to predict how the virus will evolve have been in place since the middle of 2020. And in fact, some of the mutations in Omicron and their potential biological significance was already in place because of the experiments that started to be done 18 months ago. Experiments backed up by computational efforts, actually inducing mutations, figuring out how they would behave, and then using that to try and predict what was going to happen. I think there's no substitute for surveillance because we can come up with, as with Omicron, you can come up with a lot of predictions that are based on sequence data, but how they finally add up together for biological behavior of the virus does require you to continue to do clinical, epidemiological, and genomic surveillance. Perhaps we can rationalize the approach by trying to see where sequencing would give us most bang for the buck. Which kinds of populations, what kinds of strategies, what frequency we should use to be able to sequence. But there's no getting away from the fact that we need the capacity.
Right. Thank you. Thank you, Professor Kang. Professor Reddy, do you want to add anything on the genomic surveillance? You muted, Dr. Yeah.
Well, I agree with Dr. Kang. We do need to continue our surveillance. There is no doubt about it. And we need to understand how new forms of the virus, the new variants are emerging. But I think that the kind of testing protocols that are currently being followed, if well followed, whether it is entry point screening or screening of symptomatic people, should give us sufficient number of samples for analysis. Right.
Thank you. Thank you, Professor Reddy. And Dr. Anish, you're an epidemiologist, and you need data to really kind of forecast and figure out the course of this pandemic. So I'm guessing this kind of genomic surveillance data or surveillance data in general will be very critical for your work as well.
Definitely. Before answering that question, I think I have to answer some other question in the chat box. Somebody asked me to explain more on the building the system in regard to post-COVID. If you look at the COVID-19 situation in India, you can see very clearly three waves. The first wave was somewhere peaking in September 2020 with almost 1 lakh cases per day. The second wave, which was created by Delta, which was peaking in April 2021 with 4.25 lakhs cases per day. And now we are moving to the third wave. If you look at the second wave, it is by Delta. We know that it is because of Delta, and Delta is notorious for creating maybe post-COVID syndrome and so many complications related to COVID-19. If you look at the entire COVID-19 history all over the world, we can see that India was affected by Delta wave this much strongly, or this much number of people affected by Delta. So I suppose maybe after 3 months or 4 months, at the end of this pandemic, India may be having a large sequelae of post-COVID people in our community. Maybe no other country may not be having this much number of people affected by COVID-19, long-time sequelae of COVID-19 are there in the rural areas of the country. So it is very important to build the system to take care of these people, because now there is a drama. People are there, people are investing more on surveillance. We are just behind the genetic sequencing. It's very interesting to note that what is happening in the genetic makeup of the virus and all other things. But once this pandemic is over, so many people are going to be suffering from so many ailments, maybe because of the respiratory illness. So many people will be having some other ailments, maybe mental diseases, and so many things will be there. And we have to have a system in our place that will be well integrated to the primary healthcare mechanism of our country. That is very important. So we have to build that system. That is a very important, because any other country in the world is not going to suffer this much. Because any country, if you think, it was not the second wave or Delta wave was not devastating like that. If you look at Europe and US, Omicron is actually coming in the middle of a Delta wave. So that is something they have escaped from a large Delta wave because of Omicron. Omicron has replaced Delta maybe in 2 or 3 weeks time. So we actually finished the entire Delta wave, and we are heading to Omicron wave. So that is a very important thing. And second one, I think we have to build system for the future pandemics, because India is a country which has got so much biodiversity, and there can be future outbreaks, maybe new coronaviruses, new influenza viruses, and all other things can happen from India. In Kerala, I am coming from Kerala, and Kerala is notorious for recurrent outbreaks of Nipah. We are the only state or only part of the world which is reporting Nipah continuously for the last 3 years. And we have to think about building this kinds of system. This COVID-19 may be an indicator that we have to again build our own system so that the viruses could be studied well, and we have to take care of these things. We have to take care of our public. That is a very important thing. That COVID has maybe within 1 year or 2 years, COVID-19 pandemic will be over. But this long-term sequelae because of COVID-19, which is going to create a large problem in India, and we have to think and talk about that also.
Yeah, that's. Thank you for raising these really very pertinent points, Dr. Anish. And maybe in a bit, we'll also talk a little bit about what is pandemic preparedness for a country like India should look like. Before that, Center for Disease Control, CDC, in the USA released some data last week that suggested that Pfizer and Moderna boosters have been quite instrumental in fighting Omicron infections and have been quite effective at keeping people out of hospital after they had been infected by this variant. So what are your views? I mean, for all the panelists who've been following this on vaccine science, on the use of boosters in India, and are there any studies underway in the country to understand the effectiveness of booster doses in India? So I don't know, Dr. Kang, if you want to go first, and then the other speakers.
So I kind of live in hope of effectiveness studies done at scale in India. I haven't seen them yet. What we've seen is largely very, very small studies that have a lot of confounders that have been published from the country. So as far as I'm aware, there are a few studies that are looking at immunogenicity of booster doses. Certainly no studies that are looking at effectiveness of booster doses being done at a reasonably large scale. So I hope it happens, not happening yet.
Right. And what about the data on the use of heterologous doses, the combination of vaccines? So now we have quite a few vaccines at our disposal. So Are we doing any studies to study the effectiveness of using these combination of vaccines?
Well, effectiveness has very defined meaning that requires a clinical outcome. There are no effectiveness studies looking at homologous or heterologous boosters in the country. There are studies that are looking at immune responses with heterologous doses. And there's one that's being done in Vellore that uses Covishield and Covaxin, which has just finished recruitment. So there should be data in the next month on how people with a baseline Covishield or Covaxin immunization respond to the same or a different vaccine being given. Hopefully, we'll be able to do that with the other vaccines that have been approved in the country, Covovax, Corbevax, Zycov-D. But I know that Corbevax has asked for a study to be done for booster doses, but I'm not aware of the others being tried out as booster doses as yet.
Right. So will I mean, again, there is a little bit of connection between long COVID and also, vaccinating, the entire population, because we cannot leave everyone out if there is a risk of people getting long COVID or having severe effects of the infection. So, I mean, where are we on that, on our vaccination policy, Dr. Reddy, if you can come in here on vaccinating everyone and also, using the booster?
Well, I believe I cannot speak on behalf of the government, therefore I cannot really know what our vaccination policy is.
Right.
However, I believe that it's absolutely important at this point in time to protect the most vulnerable and the most susceptible. Most vulnerable are the people with a relatively weak immune response, either to the previous vaccinations or to the natural infection or a combination thereof. And the most susceptible are the people who are exposed repetitively to high viral doses, and these are the health workers and other essential workers who are likely to encounter a large number of persons suffering from COVID, and therefore they may become vulnerable in the sense of their immunity getting overwhelmed by high viral loads. So they are the ones who need to be really protected at this point in time. Apart from that, people who are immunosuppressed or immunocompromised at any age. Then once we achieve that, and if we have a sufficient amount of vaccines in our supply chain, we might then consider boosters to other adults, particularly those in the 45 to 60 year age group, who also have considerable comorbidities in this country. In fact, many of our non-communicable diseases occur at a much younger age. And then come down the age spectrum, down into younger age groups and possibly immunized children as well. But let us hope in the meanwhile that our containment measures will actually succeed in reducing transmission rates and also coax the virus to become less virulent. And if it doesn't really replicate beyond the nose and the throat, like Omicron is supposed to do, perhaps we are not going to see that much of long COVID. But I completely agree with the position that it is the primary care system that is really going to tell us how many cases of long COVID are there and what the clinical spectrum is and how the care should be provided for long COVID. But also the entire area of surveillance is going to be strengthened only if we have a strong primary care system with early symptom-based syndromic surveillance of households by primary healthcare teams and early testing, or at least clinical evaluation to identify whether it's likely to be COVID or not, and then triage for home care versus hospital care. All of this depends upon a very strong urban and rural primary healthcare system, which has been constantly neglected over the years.
Right. Thank you, Dr. Reddy. Very, very important points there. Dr. Satwik, do you want to add anything? Yeah.
So a couple of points I'd like to make here. First of all, I think any discussion on boosters in the Indian context will be a theoretical discussion because we're going to ride Omicron without boosters. Also, South Africa seems to have done reasonably well without boosters, and that's because of the massive hybrid immunity that was prevalent in the community, which is a combination of natural infections and double vaccinations. But there's something I'd like to state here. We are also riding Omicron with practically a third of our population demographically, which is under the age of 15, not vaccinated. Right? Now, there are various arguments here. One argument is that, there was reasonable seropositivity amongst kids that was noted. So do they really need a vaccine? Should we wait it out? And so on.
Right.
But I would like to draw the attention of your audience to a very interesting report that was published recently by Access IBSA and MSF, Doctors Without Borders, about access to mRNA vaccines. Now, let's say, for instance, we're done with Omicron, but let's say sometime in the future, we have to deal with another variant, which might cause global distress. Which are the vaccines that are the quickest to scale up? Which are the vaccines that are quickest to reformulate? So let's say the mRNA vaccine, its manufacturing process is a chemical process. It's not not a biological process in the sense that it doesn't need cell lines and peptides and biological components. And there's an interesting report by Imperial College and MSF which revealed that pharmaceutical companies which have the competency of manufacturing sterile pharmaceutical injectables can manufacture mRNA vaccines. And this isn't a theoretical assumption. I think Moderna's vaccines are largely manufactured by a company called Rovi in Spain, which has no prior experience of manufacturing any vaccines. It basically is a small molecule manufacturer. So if at all we are to quickly reformulate vaccines, because let's say a batch of active ingredients of mRNA vaccines takes about 7 days, as opposed to a month for adenoviral vector vaccines. If you have to reformulate very quickly mRNA vaccines, it takes about roughly a month, as opposed to 5 to 6 months for adenoviral vector vaccines. So I think our government should be, speaking to the mRNA vaccine manufacturers for voluntary cooperation. And this report has actually identified 100 pharmaceutical companies that are in a position to very quickly manufacture mRNA vaccines. So, the preparedness for the future would possibly involve moving this technology into India for possible manufacture of these vaccines in the future, and possibly reformulating vaccines in case we are to encounter a variant that might cause distress.
Yeah, that was really, really informative, and thank you for sharing that, Dr. Satwik. We'll have to kind of attack from multiple directions and kind of really bring sectors and disciplines together to address this crisis. And so there's a question in the Q&A box. I mean, considering we're on the topic of vaccines, somebody's asked, how often should boosters be taken? And is it better to take a cocktail rather than the same vaccine? And if the effect of the vaccines and boosters last for a few months, and are we still protected or not once the period of protection is over? I guess this is a question and a concern a lot of people have about vaccines and how long they offer protection for. So if anybody would like to respond to that question? Any of the panelists, Dr. Satwik? Yeah.
Well, I think we are not entirely sure how long boosters will work. Also, because we'll also have to, at some point, consider whether vaccines manufactured using the original grandmother ancestral strain of the virus will be useful in the future, and they've served us incredibly well so far. And I think practically every vaccine has demonstrated the ability to prevent severe disease and death. But it's just a question that needs to be out there. Whether second generation vaccines need to come in, whether the answer is actually just repeating boosters or perhaps a whole new a different kind of vaccine. And this is eminently Professor Kang's domain, so I think she's best. It's best if you ask her.
Yeah. Professor Kang, do you want to come in here?
I actually think the fewer boosters, the better. Because quite frankly, you want an immunization program that is sustainable, that gives you the best possible protection for the longest possible duration. So I think some of the hurry that the Western world has shown to rush towards boosters has been inappropriate at best. Yes, you want to protect your clinically vulnerable people as much as possible. And in the absence of data, taking precautions is helpful. But by and large, what we should be doing is doing the research to make sure that we have the vaccines that give us the broadest and longest lasting protection. That may come from cocktail vaccines, that may come from mixing and matching vaccines, but until we do the studies, we will not know.
Right. Thank you, Professor Kang. We're seeing now that in many countries, despite there being COVID cases, they have started to ease out restriction measures. Like in UK and Ireland, they're completely dropping many of these restriction measures. So how do you think this will impact the spread of the virus globally? Because this was a pandemic that impacted the whole world. So what should India, you think, should be doing in light of these changes globally, the different kind of measures being adopted by different countries? What should we be doing in India in the times to come? So Dr. Reddy, do you want to take that?
Well, it's absolutely important that the society resume its normal functions in a phased manner, not necessarily suddenly rush headlong into complete abandonment of caution, but at the same time not sit petrified in isolation. And therefore, we do need, particularly education, school, college education has suffered a great deal, and a number of other essential social functions have suffered also considerably. Right. And people's daily lives are adversely affected. People in the lower socioeconomic groups have been badly affected. So we do need to resume. We have a considerable amount of knowledge at the moment, and we have a considerable amount of access to protective technologies as well. We know, unlike in the beginning of the pandemic, that masks are extraordinarily useful in preventing person-to-person transmission. Use them well. Right. If CDC says in the last couple of days that everybody must wear an N95 mask, and it's the same CDC which said masks are useless or not to be used at the beginning of the pandemic. But now there is a different sense of understanding. There is no reason why politicians who distribute freebies to everybody for elections cannot distribute N95 masks to every family in India. It doesn't cost that much anyway. So, I mean, in the larger scheme of things. So do protect people with the adequate amount of masks, and where we know physical distancing is not going to be easy, but at least ensure in classrooms and elsewhere adequate ventilation to the extent possible, and prevent super spread events, large gatherings for some more months to come, and then but resume educational activities, essential economic activities, and other essential social activities while keeping yourself protected. Because now we also have a considerable amount of protection provided by vaccines as well as natural infection. A good proportion of the population is immune, or at least reasonably protected against severe forms of the disease, even if they are not going to be protected against infection per se. So I think we do need to resume normal life in stages, not by abandoning caution overnight, but certainly moving forward with a greater sense of confidence.
Right. Thank you. Thank you, Dr. Reddy. Dr. Anish, do you want to come in? Do you want to respond to this?
Thank you. I also think in the same line that of Dr. Reddy, if you look at these strategies, all these are weapons which has got a use in a particular point of time. For example, vaccines. When the vaccines are made up of Wuhan strain, it was giving you some kind of a sterilizing immunity That means if I was going to receive vaccination in somewhere in 2020, the infection might have prevented. So, but later what happened? The virus has changed. Vaccines are not going to give you a sterilizing kind of immunity. It is but definitely it is useful to prevent severe kind of infection. So rather than preventing infection, the use of vaccination is to prevent severe infection or death. At this point of time, definitely more important to just look at or to check the distribution of the vaccination. The vaccine equity may be more important than giving boosters and again boosters to just have a margin of benefit. But if you are able to give the additional doses of vaccine in your country to some African countries or some poor countries, definitely it may be more useful. And these kinds of emergence of new variants could be prevented. So maybe for the first dose and second dose, giving vaccination in your country may be more important. But you have to think that maybe more important than boosters is giving or checking the distributive justice in vaccination. So that is a very important thing. Similarly, Similarly, if the disease is going to transmit or just before the community transmission, severe kind of restriction is actually very important. Because if you are going for a containment measure, you can prevent the massive infection and you can spread or flatten the curve, and definitely it is going to give you some kind of an advantage. But if there is a rampant community spread, and is it because of Omicron, that is maybe a mild kind of variant. If you are going for some social restrictions, that means you are not allowing people to leave. That doesn't, then I think we can go for masking, maybe social distancing. People can take care of themselves. We try to build their capacity. We try to build the primary health system of the country. You tell people that you have to take care of yourself. Even if it is Omicron, it can transmit to a larger extent. So these kinds of communication should be there. If you look at the situation that is happening in India, what happened at the time of Delta? The wave has come and so many people affected in a very small window of time, and the wave has disappeared. And the same thing is happening in the time of Omicron. What does that mean? That means India actually somewhat failed to build the social system that is able to prevent the infections. So if for public or for we were able to build that kind of a social system to teach our people to reduce infections, then the infection will be coming very slowly and it will be disappearing very slowly. But what we are seeing in India is when Delta was there, so people were suffering from Delta, and in a fine morning, the whole Delta has disappeared from the country. People were just going to malls and all other public places without mask. When Omicron comes, the same situation is happening again, and we are not trying to study anything out of that. So that is a very important thing that we are not studying from the pandemic. The essential public health messages are missed in India, but that is what I feel.
That's really important points there, Dr. Anish. Thank you for sharing. And there's a question on the topic of vaccines. There's a question about whether vaccination should be a choice or not. And somebody's asked that there are in some countries people are prohibited to work if they are unvaccinated. So should it be, or is imposition is it? So would the panelists like to respond to that?
Yeah, I comment on this.
Sure.
Look, I think increasingly as a community, we must, and as a society, we must move from a culture of mandates to a culture of responsibilities. And that's the admirable thing to do. But I think it's equally important from the point of view of messaging. And I think green passes and vaccine passports are a form of self-delusion in 2022 because they signal the false and the falsified notion that double vaccinated is equal to not infectious. All right. We must, and there's this strange kind of behavior that you notice, particularly in the metropolitan areas. A friend of mine who got infected recently said, I think I caught it at a cafe because there was this one person who was not vaccinated. There's this idea, this notion that the people who are not vaccinated are unsavory and unclean and contaminated. And it's not in the spirit of inclusivity. So we must not only construct an intellectually coherent view of vaccines, but also a morally coherent view of vaccines. And our fight against anti-vaxxers should not be based on conviction, but should be based on evidence. And currently, there is no medical or epidemiological logic of vaccine passports, because the advantage in terms of prevention of transmissibility is practically non-existent. So this might be sacrilegious, but I think the incentive, the fact that 90% of people on ventilators in our hospitals currently are unvaccinated should be the incentive for someone to take vaccine. It's not excluding people from realms of activity. Today, the headline is that only double vaccinated people are allowed for a public day and on production of vaccine passports. This has no epidemiological logic. I'm sorry.
I entirely agree. I entirely agree. People who are vaccinated with the current vaccines, which are non-mucosal vaccines, can get infected and can infect others. Vaccines will prevent severe disease and death and hospitalization in most of them, but does not reduce the potential for infectivity, absolutely. And therefore, this kind of imposition is absolutely uncalled for, both in terms of science and in terms of proper human rights.
Right. Dr. Kang, do you want to share your thoughts?
Well, while I don't agree with vaccine mandates, I do think that promoting vaccination is absolutely essential. Making sure that people are educated, making sure that vaccines are available, that opportunities are provided to people to get vaccinated makes absolute sense to me. Where vaccine passports are concerned, if there is a situation where with a reasonable degree of certainty that people are likely to be less infectious, then maybe there are situations where some form of certification might have value, but there are lots of maybes and mights in there. I do think that when we begin to think about what the future looks like, while I don't agree that the government should agree that people should be vaccinated or not vaccinated, I think if I take the situation of schools and some schools saying that, if children are unvaccinated, we don't want them coming into school, a stage will come where unvaccinated children may be transmitters. And at that stage, we might want to think about criteria for what is allowed and what is not allowed. We've seen that with other transmissible viruses, people who carry infection, who are potentially infected and infectious, can be a threat to those around them, particularly people who are immunocompromised. So if we have a responsibility to the weakest in our society, I think encouraging vaccination is not wrong, but I don't think it necessarily should be mandated.
I also agree with Dr. Kang in this regard, because in India, to endorse the public strategy, just like vaccination, is very important. Because it will help, it will go a long way, especially in childhood vaccination and all. This is a context, or this is an opportunity that we have to endorse the public health strategy of vaccination. COVID-19 may be a very good context for that, to vouch on that.
Right. Yes. Thank you. Very interesting thoughts there. And thank you all for sharing them so candidly. There's a question. I think there's a lot of concern regarding young children and, how we're probably not doing enough to protect them. Or how COVID is impacting them. So maybe I know that we've touched upon this, but this question has come up a couple of times. So can I request one of you to probably just come in here and talk a little bit about the kind of risks there are concerning young children, and of course, it would be ideal if everyone gets vaccinated, but until then, what should be done?
Well, when it comes to young children, the first thing to understand is that there is very low risk, that we don't have a measure of long COVID in young children. We certainly don't have it in India, where seropositivity was at 60% about 7 months ago and is presumably higher now. And we don't know what the best vaccine is for children. Is an inactivated vaccine going to give them some level of protection? Yes, absolutely, it will. But is this the best vaccine to be giving children? I don't know.
Right.
So, given that the rest of the world has a different experience with vaccination of children, I think we have a great deal more to learn before we can be categorical about saying that we must vaccinate all children with the only vaccine that we have available at this time. I think vaccinating children is going to shape their immune response, particularly if they have not been previously exposed to all subsequent exposures to the virus. And that is a responsibility we have to be willing to take. Did we set them up right? We know that with influenza, this happens. With influenza, you have the principle of original antigenic sin. Your first encounter with the virus or a vaccine shapes your subsequent responses. Does this happen with SARS? If it does, then we'd better know a lot more before we willy-nilly vaccinate children with the only vaccine that we have available.
Right. There's a question also in the chat box about what is the status of the prescription COVID-19 pill, and are there any side effects to treating the virus with this pill? So I'm guessing they mean molnupiravir, I think the Merck pill. That has been rolled out in India as well. Any thoughts on that?
Well, as I mentioned, that the evidence on this drug comes from Delta,
right?
And you have a certain percentage reduction in hospitalization when you use this antiviral.
Right.
But that's against Delta. We're dealing with a virus that is demonstrably milder, and in which case the risk of hospitalization is much, much lower than what it was with Delta. So should you be administering this drug is a question that needs to be answered. And also, as I mentioned, that there is a mutagenic potential. We don't know the long-term consequences. In fact, people who had enrolled in the trial were asked not to have, heterosexual intercourse or use contraception, because there was this risk that at the bogey of the risk of mutagenesis and carcinogenesis, which needed to be addressed. What I've noticed is that if a drug is introduced into the market, more often than not in South Asia, it's indiscriminately used. I mean, I've seen prescriptions where young people at no risk with, a couple of days of sore throat have been given this pill, and it beggars belief. I mean, this is this should be condemned in the severest possible way, because there's absolutely no evidence for using it in such circumstances. So I think you have to be very, very careful when a new kind of drug is available for use, and use it very, very selectively.
Right, right. Yeah, absolutely. So I just another question that I had was, every time now someone coughs or sneezes, we immediately think of COVID. It's almost as if magically all other viral, bacterial, and other infectious diseases have just disappeared. So, Dr. Reddy, since the start of the pandemic, we have rarely heard of any other diseases, not TB, not diabetes, not other communicable diseases that India kind of has a large burden of. And so did we lose sight of other diseases of that have significant consequence for India in the last 2 years? I mean, how are we doing on those fronts?
No, that's been an unfortunate effect of the focus on the pandemic, which of course certainly required a lot of attention, but not completely blinded to other health problems that require attention too. We know that in the initial stages, antenatal care suffered and institutional deliveries came down. They picked up speed later on, of course. But the treatment of tuberculosis, which again is a huge national priority, that has suffered. And of course, care for diabetes, hypertension, and all of that has suffered. And a lot of surgeries were postponed. So we have seen low priority being accorded by an overburdened healthcare system, which was preoccupied with COVID care and then subsequently with vaccination duties. And that is where I believe we need to really ensure that we have a much stronger and better equipped healthcare system, particularly with a strong emphasis on primary care. And unless we have an efficient, equitable, and empathetic healthcare system functioning in steady state conditions without a public health emergency, we'll not be able to build a strong and swift surge response when a public health emergency challenges us. And then we'll be fighting only on one front, ignoring all other priorities. Right. So I believe it's absolutely important that we pay attention to other health conditions as well. And if Omicron gives us a breathing space, we must try and attend to all the things that have been neglected in the past, but then also learn the lesson that we must indeed strengthen our health system, particularly our primary care and secondary care systems, so that we can attend to many health problems that demand attention.
Right, right. Thank you, Dr. Reddy, and completely agree with you. There's just another question that's come in. I guess this was also discussed quite a lot over the last 2 years about whether the play a role in treating the cases, especially homeopathy and Ayurveda. Thoughts on Dr. Anish? Hello, can you hear me?
I did not hear your question.
Oh, sorry. So there's just a question that's come in just now. Let me know if you can hear me now. Am I audible?
Fine.
Okay. So question that's come in is whether in treatment for COVID, if we are also employing other traditional treatment modalities like Ayush, Ayurveda, or homeopathy alongside modern medicine. So what are your thoughts on that? And of course, other speakers as well.
Actually, if you look at the treatment part or the management part of COVID-19, in some aspect of that, we cannot go for unscientific or yet to be proved techniques. For example, especially in the transmission dynamics, if you want to prevent COVID-19, can we use some homeo medication or something like that as a preventive medicine? We cannot, because we cannot afford. If that is not working, we cannot afford. So if you go for maybe instead of vaccination, in the place of vaccination, we cannot use any other medication or any other technique because we cannot afford. But in case of, for example, post-COVID, suppose in rural India, suppose we do not have any other system in place, and if there is a lot of traditional systems are there, they have got a good practice of doing all these things are there, that could be utilized. So if we know that India is a region for so many traditional approaches, and many people might be benefited out of that. There is nothing wrong in using these systems if the other systems are not in place. But if instead of just vaccination, or instead of in the mask, you cannot use a tablet instead of mask, or do not give some kind of a false notion that taking some medication are going to cure the disease or to prevent the disease. So that is, we have to be very, very thoughtful on that. It is not wise to use maybe yet to prove techniques to prevent the diseases just like COVID-19 or any infectious disease for that matter. That is what I understand.
Right. Thank you so much. So I would request all the speakers to leave us with their final thoughts. What's on your mind right now? What should we be looking forward to in 2022? How should we be taking care of ourselves this year? And just some final thoughts on you, all of you, before we wrap up. So, Dr. Reddy, do you want to go first?
Well, I'm hoping that given the signals that Omicron has given us, that we will probably be seeing the pandemic wane over the course of the year, and we'll be able to substantially resume normal life without threatening new variants emerging. If at all the variants will emerge, they're likely to be, again, following the same track of getting milder in terms of their disease manifestations. But I'm also hoping that that will not take away the attention from public health and health systems, that we must recognize that continued failures in public health will be the banana skins on which our economy will keep slipping. And therefore, we must attend to the task of strengthening our health systems and ensuring that all health challenges are well met in the future.
Thank you, Dr. Reddy. Dr. Kang, do you want to go next?
I think it would be great to see a system that does focus on delivering better, stronger primary care, because that's the foundation on which we have to build. But I think what is also critically important is that we understand that this particular infection is going to be with us for a while, and we make the policies now so that the ways in which we handle surges in cases are more predictable than what we've had in the past.
Right. Thank you, Dr. Kang. Dr. Satwik, final thoughts?
Well, I'm not equipped to say what the trajectory of this pandemic will be. A lot of people have said that we are possibly with Omicron, we are moving to a state of endemicity. My submission would be that I don't know if that's going to happen, but it might accelerate a movement towards the state of endemicity. But there should be eternal vigilance, which comes from surveillance and sequencing as regards newer variants and a major antigenic shift that might cause distress. And a part of this preparedness would come from moving technology, which allows us to manufacture vaccines very, very quickly. Perhaps mRNA vaccines are the route for that.
Thank you, Dr. Satwik. Dr. Anish?
I also think that COVID-19 is just like a litmus test for our system. Maybe in the local level to the international level, we know what is our pitfalls. And we may, if you are able to sit back and think, we may be a better society in future, and we can tackle maybe future challenges that may be there, because that may be there in increased frequency. There could be another pandemic that can happen in our lifetime itself. So at that point of time, I think we as human race, we will be more equipped, and we can just face our problems, and we can correct our system. That is what I think.
Thank you so much, and again a very big thank you to all the speakers for so patiently responding to all the questions, and also to our audience for joining in, and of course, Asia Society India for hosting this very important and pertinent discussion. And I think if there's one thing we keep hearing is that this is not going to be the first pandemic, and this is not going to be the last. I mean, this is not the first pandemic, and this is not going to be the last one. And we need to have better health systems in place. We need better pandemic preparedness. We need to listen to science and hope, like Inakshi also mentioned in the chat, that hope we can all see normal times very, very soon. So a very big thank you to everyone, and I hope we don't lose sight of all the other health problems and the disease burden that India has. And while we fight this pandemic and this infection, we are also at the same time looking and taking care of other problems that ail our country. So on that note, thank you very much, all of you, for joining in. And I hope you continue to take good care of yourselves and have a very good night. Thank you.